So without further ado, we're going to start. Our very first presentation is a scientific investigation entitled The Utility of Sugamidex Storage for Emergent Reversal, and will be presented by Dr. Kevin Varner, a resident from Ohio Health Doctors Hospital.
Hello, my name's Kevin Varner. I'm one of the CA3s over at Ohio Health Doctors Hospital. And like they mentioned, our study is called the Utility of Sugamidex Storage for Emergent Reversal. So the principal investigator is my program director, Matthias Franson, and then we also worked with Austin Schaefer. He's one of our junior residents, and I want to give special thanks to Teddy Renner. He's a med student who went above and beyond helping us on this. So he can't be here, but if there are any other program directors out there, he's fantastic and did a great job. All right, so the idea behind this study was we wanted to use simulation, and we wanted to use it in a different way than just education. We wanted to use it as a quality improvement, and also to be able to, I think it can be a very good tool if you need data when negotiating with the kind of the suits upstairs, the hospital administrators. And so our idea was, what if we had a Sugamidex storage kit for an emergent reversal in a can't intubate, can't ventilate situation? So at least at our hospital, the anesthesia backstands carry about the pharmacy will stock about 6 200 milligram 2 ml vials of Sugamidex in each of the backstands. And at any point in the day, as people are using them, you start dwindling that down. So we found that on the median value at any point in the day, if you were to open a backstand, would be about 4 of those. So you have about a maximum of 800 milligrams. And just as a review for some people, the reversal dose for Sugamidex is based on their twitches. But an emergent reversal dose is 16 milligrams per kilogram. So if I were to pull out my emergent reversal dose from the backstand, I wouldn't have enough in that one particular backstand. So I would have to go from room to room to go grab enough Sugamidex if I had a can't intubate, can't ventilate situation. So we wanted to see what would it be like in terms of time to getting that emergent reversal dose for that patient in our current state versus if we had this reversal kit. And so the idea was we would put a reversal kit in our central core, which is equidistant from all of our different operating rooms, right next to our MH kit. And we would do 3 trials of our current situation, and then we would do 2 trials with that reversal kit. And so this was a simulation that we had anesthesia residents and SRNAs. And so we would create a scenario where I was intubating a patient, I was starting a case, I gave rocuronium on a 125 kilogram patient, and I get into a can't intubate, can't ventilate situation, and I call for help. So for people who practice anesthesia, you know, when you call for help over the loudspeaker, a whole bunch of people will come in. And our job is, if I'm intubating that patient and things are spiraling out of control, then I need to focus on that airway. But one of the options, at least on an elective case, is to wake the patient up and get them breathing again. And so if people are coming in and loads of people are coming in, I'm working on the airway, I can ask somebody, please go get me an emergent reversal dose of Sugamidex right now so that we can reverse the patient. And I will continue working on the airway, whether that's trying to mask the patient, get an LMA in there, or trying to intubate the patient while they go to get that. So we ran these trials, 5 iterations for each of the participants, and the learning points were we wanted to use simulation to improve the administration of Sugamidex in can't intubate, can't ventilate situations. We wanted to assess the utility and cost effectiveness of Sugamidex storage in an emergency reversal kit for can't intubate, can't ventilate situations. And then we wanted to train our anesthesia learners to assist anesthesia providers managing the airway. So sometimes if you're a medical student and you're on your rotation and somebody says, go get this, being able to at least just go retrieve something in an emergency is beneficial, or interns or anybody else who's in the room. So those were the 3 learning points. And like I said, so the first 3, we had a situation we would say, I have a can't intubate, can't ventilate situation. This patient's 125 kilos. Can you go get me emergent reversal dose of Sugamidex? So this first would teach the participant what the dose is, so they would make that calculation, and then they would have to go find that. and they would run around and grab all of the Sugamidex from the different operating rooms and then give that full dose. And we would time them from the moment we requested it to the time that that emergent reversal dose was given to the patient. And then we did a paired t-test comparing each of those 3 iterations, and then on the last 2 we would say, we have an emergent reversal kit next to the MH kit, can you go grab that? And then we time those, and we wanted to see the difference between the 2. Is it a statistically significant difference to have that kit in hand and give that to the patient? Would it actually equate to patient safety? So in the results, I know it's kind of hard to see, but what we can see is that we had a very so for the first go-around, when we asked people to do this, we found a median time of getting all of the different vials of Sugamidex from the different operating rooms. We saw that took about 7.73 minutes. So obviously not very good if you're in a can't intubate, can't ventilate situation. It's pretty much useless in there. But then we would have an improvement. And I think this is kind of just where people, once they got a second attempt at it and a third attempt, they kind of learn the ropes. It's like you put a rat in a maze and they kind of bump around at first, but once you have them do it again, they kind of know exactly where the cheese is and they can go there. And that's what we had right here. So you have an improvement from 1 to 3. That's a statistically significant improvement. So they went from 7.73 minutes down to 2.91 minutes. But still, that's a very long time in a can't intubate, can't ventilate situation. And then on the second half, or on the back part of it, we had them go get the emergent reversal kit. And the first go was 2.06 minutes median time. And then the final one was 1.45 minutes. So that's a huge jump from 7.73 to 1.45 minutes. So having people practice this and having an easier access to a larger vial of that emergency reversal kit. So the anesthesia trainees are often called upon to assist with other providers in a can't intubate, can't ventilate situation. I've been there in plenty of those bad airways where the primary team is working on the airway. They should not abandon the airway to go get an emergent reversal kit, but I'm an extra set of hands, and so I can go do something like that. And that's something that I think a lot of, especially the younger, the junior trainees, when you have a bad airway, that's one of the things that a lot of people forget is part of the difficult airway algorithm is if it's an elective case, being able to just wake them up and have them breathe spontaneously. Maybe we cancel the case and try to do the airway at a later point in time. Then our study found a statistically significant decrease in the time to reversal with the emergent reversal kit. And this kit had larger vials. These were 500 milligrams as opposed to 200 milligrams. And the mean time for the anesthesia residents to successfully reverse neuromuscular blockade was 464 seconds on their first attempt without the kit, and decreased down to 175 after practice. However, once we implemented this kit, it went down from 124 seconds to 87 seconds overall. So that's a huge jump from 464 to 87. Additional lessons learned. So part of the thing about doing these simulations is not only were we able to take this data and show it to the pharmacy and the hospital administrators that this might be a worthwhile investment in terms of patient safety, that if we pay for this kit, it could be there in the event that there is an emergent airway. But we also learned things about our own program. So additional lessons were a lot of the residents and visiting SRNAs, particularly our junior residents, were not very familiar with where the malignant hyperthermia kit was in the central core. And part of that is because we may show them on their orientation day and then they're off doing other things. So it was a good learning point for that. And then learners also stated during the debriefing that the simulation provided helpful practice in assisting others struggling with a difficult airway. It at least gives you something else that you can do. In terms of references, a lot of our references were with the ASA's difficult airway algorithm, and we use this as a teaching point and kind of going through our difficult airway algorithm. And then on top of that, one thing I wanted to mention was this article that came out once when we started this project, and we were doing a literature review, was the myth of rescue reversal in a can't intubate, can't ventilate situation, which kind of flies in the face of exactly what we're doing here. But what they're saying is you can't rely on emergent reversal. Don't have that as your insurance policy. And we emphasize this to all of the learners. If you're in a difficult airway and it's just you, you can't go and try to grab an emergent reversal kit, but you can call on somebody for help. So I think this was a very good article, and I don't think it's really contradictory to what we were doing, but I think it kind of helped as a learning point. And thank you.
We really don't have time for a bunch of audience questions. I just want to ask you one thing. Have you implemented it yet? And if you have, or if you haven't, but you're planning on it, where are you going to keep this? With the MH kit or where?
With the MH kit was the idea. I would have to talk to my program director. I think he's still talking to the administration, but we're using a lot of this data to make our argument that this is a worthwhile investment. And I think that's true for a lot of Sugamidex. I know that a lot of hospitals, they don't want us giving Sugamidex. They would prefer us to use neostigmine, but a lot of anesthesiologists are saying it's a worthwhile investment in terms of patient safety to have that. And so we're kind of taking that a step further. In terms of finally implementing that, we haven't yet, but our plan would be to have it right next to our MH kit. So our ORs are kind of in a circle around our central core, and the MH kit is right in the middle of it, so they're equidistant from all the different ORs.
Okay, thank you. Our institution, we were told the Jefferson Enterprise, which is a lot of different hospitals over this past year, since we've been using Sugamidex more, have spent $5 million on Sugamidex. So it is a concern. Thank you so much.
Thank you.
Our next presentation is a scientific investigation as well, entitled Semaglutide-Induced Delayed Gastric Emptying and Anesthesia, and will be presented by Kira Wendell and Elena Reshetnikova, students from Rocky Vista University College of Osteopathic Medicine.
Good afternoon, everyone. My name is Elena Reshetnikov, and I'm a second-year medical student at Rocky Vista University.
And I am Kira Wendell. I am also a second-year student at Rocky Vista University. We were supervised in this project by Dr. Roberts and Dr. Zhang, who unfortunately will not be able to join us today.
Okay, and this is our presentation on analysis of semaglutide-induced delayed gastric emptying and anesthesia fasting times. And first, I would like to start with a brief overview of what are semaglutides. So it is a long-acting glucagon-like peptide. It's called long-acting because of its half-life of 7 days, which makes it great for a weekly administration. It is used in treatment of type 2 diabetes and weight loss. And the mechanism of action, it's a glucose-dependent insulin secretion, glucagon release inhibitor. It suppresses the hepatic gluconeogenesis, delays the gastric emptying, and decreases the appetite. And this is a nice diagram that just shows visually what I just mentioned. So basically, let me just touch upon this. So when the meal is ingested, it goes into the stomach, it goes into the small intestine, and where the L cells secrete the GLP-1, and it has a multifactorial effect in multiple organs such as liver. It suppresses the gluconeogenesis. In pancreas, stops the release of glucagon from alpha cells and increases the insulin secretion from the beta cells, and it delays the gastric emptying, which is basically the focus of our research. We are particularly concerned in this because the delayed gastric emptying can increase the residual gastric content, and in terms of anesthesia, it creates problems and complications such as regurgitation or pulmonary aspiration. And the focus of our research is that we would like to investigate the relationship between the preoperative use of semaglutide and increase the residual gastric content. And we are trying to examine the best fasting times before anesthesia or dip sedation for a minimal risk or complication during surgical procedures. And those are the learning points of our presentation. I'm not going to repeat myself, but the main focus of our presentation is the relationship between the preoperative use of semaglutide and optimal fasting times. And Kira will go in more details.
So we did want to touch on the fact that we know that the ASA does have guidelines currently for patients taking semaglutides. Those that are taking daily doses are told to stop 1 day prior. Those taking weekly doses are told to stop 1 week prior. Following that, then to do regular fasting guidelines with clear liquids being 2 hours, light meals at 6 hours, and heavier meals at 8 hours. With our methods, we did a literature search of PubMed and Google Scholar up until February of 2024, looking for patients taking semaglutides that had increased residual gastric contents. Inclusion criteria were semaglutide, increased residual gastric contents, deep sedation, and anesthesia. Exclusion criteria was if there was only an abstract, no residual gastric content were noted, or no semaglutides were involved. From our search, we were able to find 7 individual case reports and 1 significant population study. This population study looked at a 10-hour fasting time, comparing semaglutide and non-semaglutide groups before going in for EGDs. The semaglutide group had a 24.2% occurrence of residual gastric content, where the non-semaglutide group had a 5.1%. There was also 1 bronchoaspiration within the semaglutide group and none within the non-semaglutide group. Of these individual 7 case reports, 3 patients were male, 4 were female. They ranged between the ages of 25 and 70 years of age, and the fasting times ranged between 8 and 20 hours. Procedures varied based upon patient needs. 2 of the cases were aborted due to the presence of the residual gastric contents. 1 went uneventfully. 2, regurgitation did occur with no aspiration, and 2, regurgitation did occur with aspiration. Ultimately, because of these findings, we believe that there is concern for increased residual gastric contents when taking semaglutides, and that there should be a call for action with an increase in research looking at how semaglutide can affect fasting times, and ultimately how it can affect patient safety for risk of regurgitation, bronchoaspiration, and pulmonary pneumonia. Our citations include the articles that we referenced for our case studies that were mentioned in this presentation. Thank you for your attention, and we'll take any questions.
Questions from the audience? I know it's the alkaline tide, but.
She just read my mind. I was going to say the same thing.
I had a question. How do you handle if somebody does not adhere to these guidelines, as far as if it's an elective case? Do you do the case? Do you do it with an RSI? Or what are your thoughts on that?
So I can speak a little bit on my background. I worked as an anesthesia tech. I haven't done rotations outside of that, though. I think that there definitely is that risk for patients not being compliant with fasting times, and that is a reality. Looking at the cases that we saw, that's trusting that the patients were honest about how long they had fasted for. I think it would depend case by case on patients' individual risks and how much gastric content may be noted. You're able to sometimes tell that through ultrasound, so I think that would be case dependent.
That was a great answer. Audience, what do you guys do? Do you cancel a case? Do you do it as an RSI? Anyone want to share?
Usually we'll try and aspirate out, run an OG down during the case, but not necessarily completely cancel the case, unless it's some kind of case like an EGD or a scope where you wouldn't normally even have a general anesthetic associated with it. Then those are rescheduled.
The Cleveland Clinic, it's far on the west edge of where the Cleveland Clinic is. We call it Black Spire Outpost at Galaxy's Edge. It's in Lorain County in the middle of a cornfield. I think when you're looking at how everybody does it, it depends on where they're at and what their resources are. We've come to the conclusion that in our particular case, they don't follow the rules, cancelectomy, cancelotomy, and we just reschedule because they're all elective cases. So I mean, that I think I just bring that up because if you're at a hospital and it's a necessity, or you've got all your backup, that's one thing. Us in the middle of nowhere, fastest we can get somebody out of there, I don't want to think about it. And I've had to do it a couple of times when this whole rigmarole started with these agents and nobody knew what was going on.
Some of the hospitals in Fort Worth have taken the heat off of anesthesia just by saying it's a policy. 7 days off or nothing happens, period. So we don't have to cancel or anything. We just say, okay, and bow out.
I also question how effective an RSI really is, because we really don't know that. My question real quickly is, by extending the fasting guidelines, like beyond 12 hours to 20 or 36 hours, not great for diabetics. If it's just weight loss, maybe. But after, that's a very long time to be NPO, and I'll bet you your patients may start telling you they are fasting when they're not, because I get that, but I think it's unreasonable to expect somebody. And I'm also not sure, you'd have to study that to see if it made a difference, because that's pretty radical, and I don't know that it will.
Thank you so much. Our next presentation is a complex case entitled Case Presentation of Pneumocephalus Following Labor Epidural Catheter Placement, and will be presented by Dr. Vincent Relly Dempsey, a resident from Ohio Health Doctors Hospital.
While that's loading up, like I said, I'm Vince. I'm one of the residents over at Doctors Hospital. Thank you all for having me. So, yeah, this is a case presentation of pneumocephalus following a labor epidural catheter placement. I'd like to also thank Drs. Gable, Covison, and obviously Dr. Franzen for helping out with this project. So just an introduction, obviously, you know, we're all very familiar with epidurals, but it's a pretty common procedure in the field. It's usually used for labor analgesia, and it's one of a very commonly performed procedure in obstetric anesthesia. There are some risks with it, though. They include, but aren't limited to, post-dural puncture headache, and then bleeding, infection, and damage to nearby structures, like we commonly tell a lot of our patients. Those things are typically pretty uncommon, but we still have to let them know. And the less common risks include pneumocephalus, and it's typically used or associated with the use of loss of resistance, typically with air. So getting into the case, our patient was a 32-year-old female, past medical history of insulin-controlled gestational diabetes, low thyroid, macroprolactinoma, who had presented at 39 weeks for scheduled induction of labor and had been requesting a labor epidural. So for the procedure, on the first attempt, it was prepped in standard fashion. So our kits usually come with a glass syringe, which in this case was lubricated with saline, and we drew up 3 cc's of air. And it was initially met with a loss of resistance, but immediately followed by a return of CSF. The needle and everything was promptly removed. The site was covered with sterile gauze. The patient was assessed for any complications, so on and so forth. Nothing at that point, so the decision was made to move with the second attempt. Loss of resistance was again met with air, no return of any like CSF or continuous return of fluid, so nonetheless was confirmed with loss of resistance further with saline, and the negative CSF return. And then we threaded the catheter. Again, after hooking everything up, there was no return of CSF on suction with a small 3 cc syringe. And then after administration of a test dose of 3 cc's of lidocaine 2% with 1 to 200,000 of epinephrine, that was a negative test dose, so reassuring that the epidural was working just fine and in the right spot. The patient delivered later that day, and it was a pretty uneventful, spontaneous vaginal delivery. And then postpartum day 1, the patient had reported a progressively worsening headache, predominantly described in the occipital and the left forehead areas, typically worsened in the upright position. But otherwise, in this small subnote, is just no other symptoms. Vital signs were within normal limits. Physical exam was grossly unremarkable. So essentially, we assumed this was a post-dural puncture headache. So at our institution, we gave them a regimen of PO, butalbital, acetaminophen, caffeine, as well as an IV injection of hydrocortisone, Q8 hours, for like, I think it was up to maybe 3 doses tops. And then sumatriptan, 50 milligrams PO, and a 1 dose of aminophylline, 250 milligrams IV. And then postpartum day 3, symptoms were not improved. Neurology was consulted. A CT scan was ordered, which demonstrated a small volume of intraventricular gas in the temporal horn of the left lateral ventricle and the anterior aspect of the body of the left lateral ventricle. All in all, to say, a pneumocephalus diagnosis was suspected. In terms of management, however, the management was grossly the same, so we did oxygen nasal cannula, 1 to 2 liters. All the above meds were continued. However, I believe it was predominantly just the butalbital, Tylenol, caffeine combination, and the Imitrex. Otherwise, IV fluids at 100 to 125 cc's per hour, and then bed rest. And then interesting, neurology had described and recommended that avoiding a blood patch further would not be advised, which we will get into later. And then ultimately the patient was discharged on postpartum day 5 with Rex for neuro follow-up. However, on most recent chart review, there hasn't been any follow-up to this point. So, like I said, discussion with complications of this, typically you can get headaches, post-dural puncture headache, pneumocephalus, infection, hematoma, nerve damage, just to name a few. But more commonly, we typically run into some headaches, post-dural puncture headache, maybe some nausea associated with this. Pneumocephalus can have a variety of etiologies, iatrogenic obviously included. But the difficult part, A, is that it presents similarly to post-dural puncture headaches. B, it generally carries the same prognosis, i.e. the spontaneous resolution. And then C, the management is very similar, except like we described earlier, one should avoid a blood patch, which was essentially chalked up to, one, you can potentially introduce this further in, like you could do it again. And then also you could increase the pressure on the central nervous system, which can then worsen the headache in this case. So you would really want to avoid it. Unfortunately for this type of situation, there's not a lot of literature that exists on the matter. It appears to be more common with loss of resistance with air, but as with many things within obstetrical field in general, especially obstetric anesthesia, more research is needed to assess if there's any other etiologies, modalities, treatment, things we can do. And then these are my references.
Questions from the audience?
So my question is, what led you guys to get the CT scan?
It was mainly ordered by the neurology team.
Okay. And because I feel like most of us in this situation, if we tried conservative treatment, we had a wet tap, most of us would have then moved on to the blood patch. So I just find the thought process behind the CT scan interesting because that's not something that we normally do.
Yeah, it was unexpected, which ultimately led down to this because for the most part, all of us on our, like the anesthesia team, were thinking that this was mainly just a post-dural puncture headache, go on from there, treat. And again, the treatment ultimately ended up being the same thing.
Right.
But yeah.
Yeah, very interesting.
So I also think that both types of headache were present here. And that you're between a rock and a hard place. You want to do a blood patch if it's a spinal headache or a post-dural puncture headache. And I guess you don't if it's a pneumocephalus. But there is actually case report where you could say, well, we should only be using saline in our loss of resistance syringe, and then we're going to avoid pneumocephali. Well, Susie and I have a debate on that. And actually, there is a case report of using saline. And when after they threaded the catheter, there was a bad headache. And I don't know whether it was a CT or an MRI, showed air. It showed a pneumocephalus, even using saline to find the epidural space. And it was postulated that the time it takes, you take the syringe off and get your catheter to start threading it, you can entrain air through that epidural needle. So I think you're damned if you do and you're damned if you don't.
Most of our cases when we have this, we get the pneumocephalus headache immediately. We give them 100% oxygen, it denitrogenates the bubbles, the headache gets better, and I've not gone on to worry about doing a patch if they develop a post-dural puncture headache. Again, the timing is usually a little bit later than that. But we have had a few cases where we've had, not quite didn't fit, and you're right, you get neurology involved, and then they usually do get a head CT, and you see what's going on, and you make a collective decision after that. I just want to make a plug for next year's annual, where there will be a debate between the good twin and the evil twin on air versus saline for finding the epidural space, and we will see whether good wins out or whether evil triumphs.
Looking forward to that.
And Dr. Washek is also going to be talking about post-dural puncture headache on Monday. No, I'm sorry, tomorrow. So it would be a great lecture to attend as well. Thank you so much.
Thank you very much.
One final point, if there's a lot of pain with this patient, we have just started using nitrous oxide in our labor and delivery floor. Our nurses are in charge of it, and we had a patient with some severe neck problems because we tried and tried and tried to get the epidural space. You can actually get a pneumocephalus from a lot of epidural error as well. And I thought that's what was happening. And immediately our nurses said, well, let's give her some nitrous oxide till you can get something definitive here. And I'm like, no. I said, it's in our contraindications. And they're like, no, pneumothorax is, that's not. I'm like, okay, why don't you call me the next time this happens, and I will educate. So it is something to think about.
Thank you.
Our next presentation is a complex case entitled Alpha-Gal Allergy in a Parturient. This will be presented by Dr. Ursula Landman, our next president of the AOCA, and she's an attending from Stony Brook Medicine. And a clarification, as far as the awards go, it's only residents, students, and fellows that are eligible for the monetary awards. So, sorry, Ursula.
That's okay. I submitted it because I thought it was just a really interesting case. I come from Long Island, so we have a lot of ticks. So, in fact, I've gotten bit by a tick right in my backyard. So is my son, unfortunately. No matter what you do, they're just all over. We're in that whole vicinity, like the Connecticut, Long Island, so that whole tri-state area where it originated. So this is a patient. I'm going to do the button here, management of parturient with alpha-gal allergy. Alpha-gal is an allergy linked to tick bites, and it can cause dangerous risks in patients if medications are used containing it. A case of medical management of parturient is reported with alpha-gal during cesarean section. A 32-year-old multigravida G2P1001 at 31 and 3/7 weeks with triplets presents with severe preeclampsia for cesarean delivery on a weekend. So of course it's a weekend. I'm on call on the weekend. And the patient had a tick bite 4 weeks prior and presents with this new onset alpha-gal allergy. So alpha-gal, we do hold multidisciplinary meetings on complicated patients, but since this was a recent onset, a meeting was not held. Usually this meeting would occur with maternal fetal medicine doctors, the obstetricians, and the obstetric anesthesiologist to plan for the patient. We hold them sometimes even 4 times a week, depending on how the patients pop up. We just do these meetings on Teams usually. And the pharmacy would also be a good addition to consult in a patient with this history. So it was determined there was no contraindication to neuraxial anesthesia. I had a really busy morning, but I was on the phone constantly with pharmacy. The anesthesia attending had multiple discussions with the pharmacist on call since this was an urgent case. And a number of obstetric, anesthetic, and vasopressor medications should be avoided due to their ability to have components triggering to alpha-gal patients. So basically we had to check each medication by the lot and the manufacturer number. It was very tedious. And then if I didn't have the right lot or manufacturer, they had to keep scudding it up to us. So these medications have the potential to contain alpha-gal, propofol, so which we very commonly use, opioids, acetaminophen, muscle relaxants, intralipid, and heparin. Hospitals may also carry more than one manufactured type of medication. So I opened up our drawer and we had 4 of this one, 5 of this one. It was just a whole medley. And I had to go through each one. Alpha-gal approved medications must be checked with the pharmacy, and the propofol utilized must contain the plant-based glycerol. So we did not have that one up there. They actually had to send that one up to us. And each medication had to be looked up for its alpha-gal triggering potential. And I actually had to speak to multiple pharmacists that morning. So every time I called, it was a different one, too, that I spoke to. The parturient received a spinal with bupivacaine, fentanyl, and morphine. So it's our typical spinal. The patient underwent primary low transverse C-section. But we had to check the propofol. We had to check everything that we might potentially need. So that was the problem, to have it all ready in the room just in case. Oxytocin was used without complications, and the EBL was 528 milliliters. The 3 infants went to the neonatal intensive care unit for low birth weight, and the patient and later babies were discharged home without complications. So discussion. For future cases, we have now compiled a list of contraindicated medications. We have it hanging in our call room. And so this is readily available to all who are on call, all who are in the OR, so that we have it on a daily basis. We also put a copy on the chart if the patient comes up with an alpha-gal allergy. And it's also important to notify the patient that the alpha-gal allergy must be told to all future, for her care, because she didn't know this, our patient, so that was very important. And then an emergency crash cart was also readily available at all times, as well as emergency medications that were appropriately checked for alpha-gal triggering. So this was a lot to check, right, in like kind of an urgent scenario. A complete report was also given to our recovery room because they also had to have the correct medications, and then to the floor nurses for continued safe care. And then the list of allowable medications was forwarded with the patient. So every medication used, as I said, must be screened into the perioperative period, so that this list is really imperative. It kind of just followed the patient everywhere we went, and then we spoke to each person that would take care of the patient that day. So this case highlights the need for continued vigilance during the entire perioperative period of patients with alpha-gal syndrome. And then the success of this case hinged upon the coordinated care and the multidisciplinary approach between obstetrics, maternal fetal medicine, pharmacy, and anesthesiology. And being a weekend, it was extra challenging because you don't have all the resources that you normally have. So that's the reason I submitted it, just because I thought it was very interesting, and it could come up. You never know from where you live.
I have a quick question.
Yes.
How did this patient present to even be tested for alpha-gal? Because you don't just test every person who has a tick bite for something like this.
Yeah, she had gone to her her OB visit, and unfortunately, we didn't have any information.
So, but she had some signs and symptoms that led them to get her
Yes,
tested.
Yeah, so that, but normally we would get a consult and we would get information on the patient beforehand.
Right.
So she just appeared to me that morning in our triage, which, was like the worst way to appear. But
And
that
I
seems-
assume once you get an alpha-gal allergy, you have it for life. Is that right? Okay.
Yes. So that's why it's important to follow up with the patient and tell them this. And we gave her like a whole, list of, so that she would know for wherever she goes afterwards, because they might not come back to where I work, Stony Brook Medicine. So
Any questions from the audience?
I'm not sure about that. I think if they're saying they have an alpha-gal allergy, I would just treat them as an alpha-gal allergy. I don't want to take that chance that, yeah, I'm not sure about that. That's a good question, though. I could try to look it up.
One other question. By having a tick bite that caused her to get alpha-gal, did that have any effect on the babies? Would the babies have an issue from the tick bite, be sensitized to alpha-gal, or become an alpha-gal positive person also?
Yeah, I don't know the answer to that. I don't know if they tested for that. I didn't see any testing when I looked afterwards on the babies. I don't know if they continue that like into the whole newborn period. Yeah, me either until I took care of this patient. So it was a learning experience just that whole morning. And I spoke to multiple pharmacists that it was kind of crazy because I was like reinventing the wheel each time I spoke to them, and then having to check each medication, and they never heard, so they were checking each medication too. And it was, yeah, it was a lot for morning class. Thank you.
Residents, students, fellows, aren't you glad she's not up for the award? Anyway, next presentation is a complex case entitled Diabetic Deconditioning, an Uncommon Use of Botulinum Toxin to Promote Therapies. Then it will be presented by Daniel Navid, a student from University of North Texas Health Science Center.
Hello everyone, how are you guys doing? My name is Daniel Navid. I'm a fourth year medical student at the Texas College of Osteopathic Medicine. About a year and a half ago, me and a couple other students did this case study on a patient looking at botulinum toxin as a potential therapy for diabetic gastroparesis. I'm not sure how many doctors and physicians in here are dealing with gastroparesis on a daily basis. However, botulinum toxin this case kind of shows the diversity of botulinum toxin, all the different ways it can be used. It has a very interesting mechanism of action, like I'll talk about here in a second. So this is a really cool case and something very interesting. So just a little bit of background and introduction. Sorry, I don't have it in a PowerPoint format, but I'll kind of try to keep it organized for you guys. Just for the introduction, gastroparesis affects about 300 patients out of 100,000 in the United States. It doesn't have a lot of acute treatment, so the main way we're going to treat this is using diabetes medication, get their blood sugar under control, and then we can kind of look at the long-term effects. But in terms of acute treatments, there aren't many, and that's when the botulinum toxin can come into play and be really helpful. So looking at the kind of mechanism of action, just a review of the botulinum toxin, it works at the acetylcholine receptor. It inhibits exocytosis of the acetylcholine, and that results in muscle relaxation. And something I didn't mention earlier, gastroparesis is going to affect the smooth muscle in the abdomen. So you'll have decreased gastric emptying, and it really affects that pylorus sphincter, and that's where this case will come into play. So getting into the case a little bit, this was a 25-year-old female. She came to the emergency department with excruciating abdominal pain. She had some labs done. She was admitted to the hospital, and she was in diabetic ketoacidosis. They did a CT scan, and GI was consulted, and they recommended doing a gastric emptying study. There was delayed gastric emptying. As you can see, the red arrow is pointing at the pylorus sphincter, and it is showing that constriction there. So it was recommended by the GI team to go ahead and do this botulinum toxin injection into that pylorus sphincter. Obviously, if they're in the hospital getting treated for this diabetic ketoacidosis, you will see improvement, but it is cool to see that potentially that this injection was a way to help. So just looking at the cycle here, she came in, she got admitted, they did the injection endoscopically, and she saw improvement. She was able to tolerate PO intake. She was able to pass bowel movements again, and she just got a lot better. So I think it's a really interesting case to show the versatility of botulinum toxin. For this kind of discussion and conclusion section here, so I talked to a couple anesthesiologists, pain doctors, Dr. Klassen, for example, and honestly, they utilized botulinum toxin a lot more than I expected in their pain management practices. They mentioned for torticollis, migraines. So there's a whole wide variety that this management can be used for, and I think it's just kind of an exciting, cool case presentation. So thank you guys for your attention.
Questions from the audience?
Yes, they did it endoscopically through the scope, so I thought that was really cool, and they can literally see you can see the pylorus, how it's constricted, and yeah, after a couple days, after some of the research I did in the past, there haven't been any double-blinded big case control studies on this. There was one study, it followed 12 patients for 12 weeks. At the end of the 12 weeks, 4 of the patients had improved gastric emptying studies, and then I think it was their pain score at the end of the 12 weeks was cut in half. So there has been some improvements, but there still needs to be those big cases to really show that this is going to be a beneficial treatment. Yeah, so the study shows that it only lasts about 8 to 9 months. So you would have to repeat it, but it is good to use in the interim because a lot of these patients they're going to need surgery for the gastroparesis. So in the interim, they're not going to be candidates for these 4 big surgeries. They have diabetes, and they most likely have other issues, so they're not going to be the best candidates. So maybe this will hold off until they can get that surgery completed.
I was going to ask you if there were other side effects from the botulinum, because years ago I had some problems with achalasia, and I had my lower esophageal sphincter injected with Botox, and I wasn't able to swallow mashed potatoes, and I love mashed potatoes.
I'm not sure about there was no side effects reported in this case specifically, but I'm not sure if others, but yeah, that is interesting as well.
I don't know if you said it, I was maybe spacing it, I'm sorry, but how did you when she had this injected, did you do an endotracheal tube? How would you, because she had the intractable nausea vomiting, I would be very scared to sedate someone like that while you're having an endoscopy and inject that.
That was something I knew you guys were gonna ask that. I don't. So this was the GI physician did this case, and then we got the information later. So I'm not exactly sure how they did that. But when I was sitting here, I was like, they're for sure about to ask me that, and I'm not sure.
So GI did this without anesthesia.
I'm sure anesthesia was involved.
Oh, you think they were? Okay, because that would be my concern there, especially, you know, you're trying to help her, but you don't want to cause a aspiration pneumonia while you're trying to help her, and she's somebody I would have tubed for that.
Did they look at her afterwards, either a POCUS or something of that nature, to see if her gastroparesis improved afterwards?
That's what I was hoping, that they would have done maybe a second CT scan or a gastric emptying study to really prove that this was beneficial, but they didn't do anything to follow up, and I'm not sure if she ever had to come back to the hospital or any management after that. So.
Thank you very much.
Thank you guys. Thank you.
Our next presentation is a scientific investigation entitled Female Authorship Trends in Anesthesiology Journals from 2018 to 2022, and will be presented by Dr. Fawaz Syed, Nicholas Sanakor, and Taj Patel, students from New York Institute of Technology, College of Osteopathic Medicine, and I'm sorry if I messed up your names badly.
Yeah. Hello. My name's Alvin Stanley. I'm OMS 3 at NICOM.
Oh, we'll just introduce ourselves while we wait. My name's Nicholas Sanakor, and behind me we have Fawaz Syed, Tej Patel, and Alvin Stanley. We're all OMS 3s from New York Institute of Technology in Old Westbury. And our special thanks to Dr. Landman. She was our advisor on this case study. So, all right, so yeah, like we said, our presentation is on female authorship trends in anesthesiology journals from 2018 to 2022. So just some background knowledge. So according to the AMC, they found that females made up 35% of active anesthesiology residents in 2023. This was one of the more male-dominated specialties, along with EM, IM, radiology, and surgery. So there were a couple studies done. They looked at the percentage of female resident trainees, and in 2005 it was around 32%, and then only a 1% increase in 2020. And this was compared to vascular surgery and general surgery, which have more significant increases of 12 to 15%. So, and some attempts to recognize this gap. So we want to emphasize more diversity and inclusion before career choice, so especially first year and second year med students. At least at our school, we don't have a lot of exposure to anesthesiology, so really emphasizing that, getting more, like this says, faculty involved that could sort of give us more exposure would really be helpful for that. So just a general description of our study. We basically wanted to look at trends in gender disparity present in these different articles for this 5-year period in 4 of the leading anesthesia journals, including Anesthesia and Analgesia and Pain as well, these 4 journals here. For our data sources, we mostly compiled from PubMed, which we compiled 7,323 articles, and in order to elucidate the genders, we used genderdize.io. It's an app where basically they give you a percentage of likelihood that of each gender. For our statistical analysis, we use ANOVA and chi-square tests.
So what we did was we took the top general anesthesia journals and, based on their impact factor, as in how much they've been cited in the past couple of years, and we excluded the non-American journals, as well as specialty-specific journals such as obstetrics, which would probably be female dominant. So we just looked at the general anesthesia journals. And so we took the PubMed search results and put it into a data sheet that, we did it through a code. We did it through a code, and it extracted the title, the author names, as well as the years. And we also looked at a multivariate regression analysis, which would show or correlate what would influence the likelihood of having female authors. So let's say having a senior female author would have more of a chance of having a first female author. And so, like we said, we use Genderize.io, which is a web-based tool, looking at the author names and going based off the database of 250,000 distinct names from 242 countries, and it would tell us the probability of that name being female. And we would include that name based on a probability that exceeded 70%. So this was a little more liberal criteria compared to more conservative criteria, so that we had a bigger sample size. And articles that were classified as undetermined, we excluded from the analysis.
So in total, we used 7,323 articles, and only about 22.8% actually had a female senior author. What we found was that 26.4% of articles that did not have a female senior author had a first female author, while 49.5% of articles that did have a female senior author had a first female author. We also found that 20.05% of articles that did not have a female senior author had a female author, while a majority of 58.97% of articles that did have a female senior author had a female author. So what this kind of shows that basically is that there might be a correlation between the presence of a female senior author and both the presence of a female author or a first female author in the same article. So we used 4 main journals for this investigation. It was Anesthesia and Analgesia, Anesthesia, the Journal of Clinical Anesthesia, and Pain. And the main reason why we used these 4 journals is because it filled 3 main categories that we had. The categories were that they were the 4 most cited journals. They did not include any like subspecialties which may have a gender predominance and cause skewing of the data. And also because they were just the 4 articles that fit the categories the best. So relative to the other journals, Pain had the highest percentage of first female authors, female senior authors, and both a first female author and a female senior author. That last category represents the concurrence of the two. Relatively, Pain also had a greater mean number of female authors in each article and a great mean percent of female authors in the other journals. As you can see in the data on the right-hand side for Pain, Pain also had the highest number of total authors, which may be the reason why there was a great mean number of female authors. However, the percents would not change. So we collected data from 4 main years, or 5 main years, 2018 to 2022, and this was because we finished our data collection in the early part of 2023, and we didn't think there was sufficient data to include 2023 in this collection. And also just because we thought that 5 years would be a sufficient amount of time for us to see like a trend. And so what we saw was that from 2018 to 2022, there was a significant increase in the percentage of senior female authors and both a first female author and a female senior author. But interestingly enough, we saw an increase in the percentage of first female authors in the articles, but it wasn't statistically significant. Lastly, there was also a significant increase in the mean number of female authors and the mean percentage of female authors in the accepted articles from 2018 to 2022. What I found interesting in this is that, like we said in the first result slide, that there might be a correlation between the presence of a female senior author and a first female author. In this one, even though the female senior author shows a statistically significant increase through the years, the first female author is not statistically significant.
All right, so female senior authorship, like Ted just mentioned, is at 22.8%, but a notable finding, which I believe he also mentioned, is that in such papers, we see a increase in 26.5% to 49.5% of having a female first author when there's a female senior author. So this begs the question, does having that a female senior author on the paper being present opened the door to having a female first author, since we do note that correlation being present. So furthermore, when there's a female senior author, there is an increase of 20.05% to just under 59% of having a female author in general on the paper. So again, we asked the question, does having that senior author being female on the paper allow for, just in general, having more female presence among the authors of said paper? So again, talking about the journal Pain, it had the highest percentage of first female authors, female senior authors, as well as having both on a paper. And in addition, it also had the highest mean number and percent of female authors per article. So potential reasons that might explain this, that may or may not have some sort of bearing on this outcome. Editorial influence. So the editor-in-chief, Dr. Davis, is active in neuroethics and equity, diversity, and inclusion initiatives. So this may promote a culture and a reputation of the journal where diversity is more valued. And pain management in general often requires multidisciplinary approaches, which promotes more diverse research teams.
So some study limitations include having this database of 250,000 names. There were a lot of names that could be undetermined. And so that would possibly skew the results in either direction, whether there's more female authors than there actually is or less. And it's also the fact that this study period ends at the year 2022, excluding trends found from 2023 and onwards, which is something we could look into in the future, as well as having a study for the past 20 years, let's say, for every 5 years and seeing the trend from there.
All right, so those are our key points. If there's any questions, yeah, that's it for our presentation.
I know we don't have much time left, but I just want to say that was a really, really well done paper, a really well done study. The things I was going to ask you, you already touched upon as far as the editorial board and whether they were females or not, which I think is important, and the reasons for pain, and you mentioned that, diversity, inclusion, and things like that. So I'm really impressed. This was really nice. Audience questions? Oh, she was going to say that. I was going to say, I find it interesting that 4 guys presented at this study.
Do you feel that may have possibly had some induced bias? Did you look into that? I assume, you mentioned that Dr. Ursula was your advisor. So I guess that counts as one female with you.
Yeah, so we were just trying to basically more compile data as objectively as possible, because we were just looking at, because since we used the Genderize app, it was more an objective study of the percentage that their name is either male or female. So we more just used the code to decipher that, and it was not our personal views of influencing it. So since we used that code, I don't think they were.
And what drove you to do the study?
Wait, can you repeat that?
I said, what drove you to do this study?
Oh, so our fifth partner here, he couldn't be here. He's big into coding, so he did a lot of the coding, and he did a previous study with orthopedics and genders, so he was also compiling this data as well, and we're all interested in anesthesia as well, so he helped us out with that. So that was the main reason.
I think also, like, all of us have grown up with women in our lives, our mothers, our grandmothers, our aunts. So I think it's important to show that influence in our lives, and especially with Dr. Landman as our advisor, she helped us a lot. So yeah, I think it was important to touch on that subject.
Well, that explains it. Anyway, thank you so much. We're out of time. All right, our last oral presentation is entitled, it is a complex case entitled Difficult Airway Management and Malignant Hyperthermia Precautions in Patients with Freeman-Sheldon Syndrome, and will be presented by Zoom, if we have that, by Fazil Kamar, a student from Lake Erie College of Osteopathic Medicine.
So my name is Fazil Kamar. I'm a third-year medical student at LECOM in their upstate New York campus. Unfortunately, I wasn't able to make it today, but I'm extremely grateful for the opportunity to nonetheless present this case. Today I'll be talking a little bit about difficult airway management and malignant hyperthermia precautions in patients with Freeman-Sheldon syndrome. So what's interesting about this case is that it kind of combines two fairly rare or exciting encounters for anesthesiologists, and it integrates it into one case. So the first is that there's a difficult airway, and then the second is that patients with Freeman-Sheldon syndrome, they're actually at a heightened risk for malignant hyperthermia. So just to get started here, Freeman-Sheldon syndrome is a congenital abnormality, and mainly it affects like the craniofacial muscles, along with the joints of the hands and feet, but more particularly, if you look at the picture of an example of the patient we have here, you can see that they kind of have microstomia, they have pursed lips, V-shaped chins. Oftentimes, these patients have a shortened thyromental distance, and these, physical characteristics make it particularly difficult for anesthesiologists to perform direct laryngoscopy. Additionally, these patients, like I touched upon, are at increased risk for malignant hyperthermia, which will further complicate the induction and maintenance plans. Of course, in these patients, you want to avoid succinylcholine and any volatile anesthetics. And mainly, you want to try your best to adhere to the algorithm because that's what's safest and that's what will minimize the risk the best. So to get into it, our patient here, she was a 27-year-old female. She had past medical history that was significant for Freeman-Sheldon syndrome, severe obstructive sleep apnea, GERD, asthma, and interestingly, she had 21 facial reconstructive surgeries kind of to help fix these physical anatomic deformities. And then most recently, she actually had a C-section, and she was presenting for a laparoscopic excision and cauterization of endometriosis and uterosacral ligament ablation. So her physical exam was significant for some of the things we touched upon earlier, microagnothia. She had poor mouth opening. Her thyromental distance was actually less than 3 centimeters, and she had severe limited range of motion of the neck. And on previous anesthetic records, because she did have so many surgeries, those surgeries were much, like when she was a child, they were much earlier. And the most recent thing we had was a C-section. Of course, it's not the best, roadmap to use when it comes to anesthetic plans to use a C-section, but that's what we had, and that's what we kind of referenced. She was actually intubated with a 6.0 endotracheal tube because she refused to be awake. She didn't want to use an epidural, so we knew that the anesthesiologist was able to intubate her with a 6.0 endotracheal tube, so we kind of used that in our plan going forward. So with that being understood, we had to take the appropriate malignant hyperthermia precautions because, of course, we didn't want to use anything that would trigger that. So we avoided succinylcholine. We made sure that this was this was the first case in the morning. So the machine wouldn't really have any volatile anesthetics, but nonetheless, we flushed the machine with O2. We used a carbon filter to make sure that it would be completely rid of any volatile anesthetics. And our initial plan when we talked to her was that we wanted to do an awake fiber optic intubation, but she refused, and she said that always in the past she was asleep, and so I guess we decided that we would go with the asleep fiber optic intubation. For maintenance, we were going to use total IV anesthetic, of course. That's what's safest and recommended for patients who are at a heightened risk of malignant hyperthermia. And so we started the case, and we used lidocaine to blunt any airway reflexes, Afrin sprayed in the nostrils in case we did have to perform a nasal intubation. Placed the patient on the standard monitors, pre-oxygenated the patient, and then we induced the patient with 50 milligrams ketamine, 50 milligrams propofol, 50 micrograms of fentanyl. And then we also used 0.2 milligrams of glycoporolate to help with any secretion she would have. But this is kind of when we ran into our first difficulty. On fiber optic bronchoscope, we saw that the patient, we couldn't really visualize any of the airway anatomy, and she had heavy secretions. And this is when she began to desaturate. So the anesthesiologist quickly aborted, and he decided to mask ventilate the patient and switch to glide scope intubation. And then thankfully on glide scope on the first attempt, he was able to note a grade 3 view. It was previously documented that she had a grade 4, but he saw grade 3. Epiglottis didn't lift up. It was stuck to the vocal cords, but he was able to pass a 6.0 endotracheal tube on his first attempt. And of course, we chose that size because that's what was used previously to secure the airway. And then from here on out, we did total IV anesthetic for maintenance, mainly using remifentanil, propofol. And the rest of the case was pretty much uneventful. We just made sure that after surgery that the patient was awake. She was breathing spontaneously, following commands, had adequate tidal volumes before extubating her. And so just a quick discussion about this case. The interesting thing about Freeman-Sheldon syndrome, and the reason why I decided to present this, is because, of course, it incorporates the two things, difficult airway and malignant hyperthermia. And then also, this is one of the most rare, I guess you can say, congenital deformities. I think she mentioned that she was the only one in the state of New Jersey to have this. And then if you look it up, there's actually like very limited literature on Freeman-Sheldon syndrome. I think they estimate maybe like 200 to 300 people worldwide who have this. So this might not be something that every anesthesiologist will encounter every day. So I thought it would be nice to share something about this, just as a, for your information. Cool case here. So I guess the quick recaps here is that you want to make sure that you're taking the adequate malignant hyperthermia precautions. I know we talked about earlier in some of the cases, like having the MH cart readily accessible, making sure there's appropriate equipment. You want to make sure that in case anything does go south, you're ready for that. And then, of course, avoiding succinylcholine. And then a lot of times people question, when I did present this case before, I thought I would just backtrack here. People question the use of remifentanil for total IV because she does have obstructive sleep apnea, but I think the anesthesiologist, he said that he decided to use this because it's fast on, fast off mechanism, and he wasn't really concerned with it causing lasting effects for her sleep apnea. And I mean, I guess ideally, if this was a perfect world, she should have been awake during this. But again, you have to cater towards the patient. And she said that she was asleep in her past, and we knew that if she was asleep, she's able to tolerate general anesthesia, and she had no contradictions to the mask ventilation. So we were more comfortable going through that, although it does kind of deviate off of the algorithm that you're supposed to use. But I think that's kind of the job of anesthesiologists to make sure that whatever you're doing it in the patient's best interest. And if it's safe, you can go ahead as long as all the precautions are there. And I guess it's important that anytime there's an emergency situation, have the appropriate equipment, be ready to switch plans. Make sure that you have the emergency tracheostomy kits, carts, everything available. And that's it. Yeah. Thank you for listening.
Hi, it's Suzanne Hufnagel. Can you hear me?
Yes, I can.
Okay. I don't know if you said it or not, but did you have ENT or surgical backup for a trach if this failed?
I'm not sure, but I would hope that they did. Honestly, I would hope they did, but I think that the anesthesiologist was comfortable taking on this case because it was an elective procedure. He's seen the anesthetic records, and he knew that she could tolerate general. So in case things went south, that was the backup plan. But I guess to be more be more safe going forward, that would probably be a good idea.
I have a question. So susceptibility to MH, was she ever tested, or was this ever confirmed with genetic testing or caffeine contraction tests?
No, this wasn't, but I think with Freeman-Sheldon syndrome, the literature suggests that these patients are at an increased risk, so it's better to be safe, I guess, in this situation. But I think if you wanted to be more specific, we could test her and see because.
All right, thank you so much. Great presentation.
All right, that concludes the oral presentations. Now, we do have one other presentation that, if you'll indulge us for another 5 minutes, we'd like to give. One of the poster presentations, our presenter was not able to get here on time, and I understand that he is here now. His presentation, again, it's a poster presentation, is a scientific investigation, and it's entitled Artificial Intelligence in Anesthesiology, a comprehensive review of clinical applications, challenges, and outcomes, and will be presented by Jose A. Arreola Patino.
Right. So good afternoon, everyone. Flights aren't always the most reliable, so I'm lucky to be here now. So my name is Jose Arreola Patino, third-year medical student at Rocky Vista University, and I'm excited to discuss a review on the integration of artificial intelligence in anesthesiology, focusing on its clinical applications, challenges, and potential to enhance patient outcomes. The use of AI in medicine, particularly in anesthesiology, has grown significantly, as well as it has in a lot of other areas. Our study aimed to explore whether AI could reduce anesthetic complications and adverse events compared to the traditional methods. The power of AI lies in its ability to analyze vast amounts of perioperative data swiftly, providing predictive insights that surpass traditional monitoring methods. So we developed a research question using the format PICO, examining whether AI in perioperative care can reduce complications. We conducted a comprehensive literature search on PubMed and Scopus, and screened just over 500 articles, and ultimately ended up with 185 high-quality studies, which included randomized controlled trials, systematic reviews, and meta-analysis. These studies were assessed for risk of bias, ensuring a robust foundation of our review using the Joanna Briggs Institute Critical Appraisal Tool. Our review highlighted several key areas where AI has shown promise, the largest category being drug administration and decision support systems, where AI-enabled decision support systems have improved patient safety by detecting errors, stratifying patients, and managing anesthesiology drug practices. These systems help reduce cognitive load on practitioners, streamline workflows, and contribute to more personalized and effective patient care. The second largest category is the intraoperative surgical complications, where AI excels in predictive analytics, allowing anesthesiologists to anticipate complications like hemodynamic instability and postoperative issues, thus improving patient outcomes. And finally, the third largest category, intraoperative awareness and monitoring, where AI techniques included machine learning and neural networks have significantly enhanced anesthesia monitoring. For instance, AI models analyzing EEG data achieved an impressive 93% accuracy in distinguishing between awake and anesthetized patients. Despite some of the successes that AI has provided in the field of anesthesiology, many AI models are proprietary, limiting customization to specific patient populations. Additionally, AI's inability to provide transparent explanations for its decisions can hinder its acceptance among healthcare providers. Therefore, future research should focus on developing transparent, bias-aware AI models that can explain their decisions, enhancing trust among clinicians and patients. AI's integration in anesthetic practice requires ongoing research and interdisciplinary collaboration for successful integration. Investment in clinical validation studies is crucial to ensure safe and effective implementation. It is also vital that to address ethical considerations, particularly regarding data privacy and a potential bias inherent in AI models. So just to summarize, AI has the potential to revolutionize anesthesiology by improving patient outcomes and reducing adverse events, but careful consideration of the challenges and continued research are essential for fully realizing its benefits. As we move forward, embracing these advanced technologies thoughtfully will be key to enhancing patient safety and care quality in anesthetic practice. Thank you for your attention, and I look forward to any questions and discussions.
Questions or comments from the audience? So this, I'm sorry, this seems to be a very general, might do this, it might do this, it might do this. Is it in practice right now, and are there specific examples of something that it has helped us with?
Yes, it's currently being used in some BIS monitors to measure the EEGs, and to measure EEGs to know how sedated the patient is. And there's monitors that companies have currently come out with to use in practice to help clinicians. And as far as I know, like some of the anesthesiologists that helped me with this, they claim that they don't receive a lot of training in EEG reading and interpretation, and it can be very vital at times. And so those monitors have helped those clinicians better manage patients.
Well, thank you so much. I'm glad you were able to get here and present.